Hi everyone, this is Ensign Flood. So today let's talk about obstructive lung disease. So when you think about obstructive lung disease, I want you to think about asthma and COPD. In both cases, there's basically a reduced ability for a patient to expire over a given amount of time. So this is marked by an FEV1 over FVC of less than 0.7. But whereas COPD is this kind of static, irreversible decrement, asthma can have improvement with a beta agonist, or in a patient that doesn't look asthmatic, they can be provoked with methylcholine. So one of the tools we use to assess this a little better is the flow volume loop. So to understand this better, we have the flow here on the y-axis and the volume on the x-axis, and I like to put a 0 out here to kind of guide me through this, because if we were to take a person and put them in a spirometer, we can follow the blue path for normal. Basically what would happen is they would have the highest volume at the end of their inspiration, and when they begin to expire air out the lungs, it's going to start fast and then gradually slow as they're trying to get the rest of the air out of their lungs until basically they get as much air out as they possibly can. Then they inspire again and the whole process resets. Now in a patient who has COPD or asthma, something that's obstructive, they can basically get a certain amount of air in, but the problem is when they expire, you can see that they can't get any more out. And basically, there's this scooped out appearance, or what we might call a lawn chair appearance. And essentially, they have all of this dead space inside the lungs. You can see there's all this volume that's trapped that would otherwise be expired in a healthy person. So just to remind you, in a restrictive lung pathology, basically what we see is a reduced amount of maximal volume they can get in. So where we're starting at the end of an expiration, basically they're inhaling as much as they can, but you can see it's a much lower volume. So when we think about treatment of these diseases, I want to start off with asthma, which is based on symptoms. So I'd like you to break it down into symptoms and nighttime symptoms. And there's 4 different degrees, basically: intermittent, mild, moderate, and severe. And you can see that symptoms only happen during the day, at no more than 2 times a week in intermittent, and we just give those people albuterol as needed. When it becomes greater than 2 times a week but not daily, and there's some nighttime involvement, that's when we want to add an inhaled corticosteroid. And when it becomes a daily ordeal, this is when we want to add a long-acting beta agonist, so salmeterol. And you never want to use a LABA alone because this can actually be lethal. So then finally, if a person is basically having symptoms every single day, all day, and nighttime symptoms greater than once a week, we want to be considering not just the SABA and the LABA, but maxing out the inhaled corticosteroid. And if that still doesn't work, that's when we add the PO, or the oral steroids. Now, if a person has an exacerbation, I want you to think about oxygen, albuterol nebs, IV steroids, and ipotroponium, which is an antimuscarinic agent. But beware of a couple of signs, in particular the cessation of wheezing and also an increased PCO2, because this basically is impending respiratory failure, and that's when you want to intubate these people. Now, going into our COPD, there's a couple of different types. We have our chronic bronchitis and our emphysema. So remember our blue bloater versus our pink puffer, right? So the blue bloater is sort of a larger individual. They're cyanotic. They have a bunch of peripheral edema, a lot of wheezing. Pink puffer for emphysema, this isn't a clinical diagnosis like chronic bronchitis. This is actually radiographic. We're going to basically see those flattened out diaphragms. These people are kind of barrel chested. They have severe dyspnea. Oftentimes they're very thin because they have to work so hard to breathe, and they have a silent chest. So one thing I want you to remember is if you have a patient, and especially a young patient, younger than 45 typically, that has signs of emphysema and liver involvement, or a family history of either two, I want you to consider the alpha antitrypsin deficiency, because remember, excess trypsin is what's basically cleaving all the proteins that hold alveoli together. And so if you don't have the antagonist, you're basically going to destroy all your alveoli. So How do you manage somebody with COPD? Well, as opposed to symptoms like asthma, we actually go through the FEV1 over FVC. So you can see basically the diagnosis is constant, it's below zero point 0.7. But looking at the FEV1, you can see as it goes further and further down, we advance to very severe. And the biggest thing to remember is to always give vaccines. So we like to give our Prevnar, which is the 13-valent anti-streptococcal and flu vaccines every year. Start them off on albuterol. Then we might want to add an antimuscarinic, so ipratropium, long-acting beta agonist, so salmeterol. And then as they get more severe, that's when we add the IACS, inhaled corticosteroids. And if these patients get really bad, so they're breathing less than 88% oxygen at room air, give them oxygen. And the mortality reduction in these individuals is based on giving oxygen or smoking cessation. But if you have to choose between the two of them, smoking cessation is the most important. So in an exacerbation of these individuals, they're going to be worsening, having a harder time breathing, having cough. Sometimes the cough will be productive. And I want you to remember the acronym OASIS for exacerbation. The way that I remember it is oxygen, albuterol, steroids, ipratropium, and Pseudomonas. I know there's a P in front, but it's easy for the acronym. So remember, and I talk about this a little bit in Infectious Disease Week, that if you have an exacerbation, so you're worried about pneumonia, if it's more community acquired, then azithromycin will probably work. If they have a morbidity, and these people do, then probably want to give them moxifloxacin. If you're thinking full-blown Pseudomonas, which these individuals with COPD have a predisposition for, then think about piptazo. So in summary, asthma is a responsive type of decrement to FEV1 over FVC. COPD is not. That cutoff is less than 0.07. Remember on the flow volume loop that obstruction looks like a lawn chair? That asthma is going to be managed in a stepwise manner based on the symptoms and the night symptoms. So short-acting, ICS, long-acting, max out the inhaled corticosteroids before you move to PO corticosteroids, and never give long-acting beta agonist alone because it can be deadly in both the case of asthma and COPD. Remember COPD, you have bronchitis and emphysema, so these are your blue bloaters and your pink puffers. And don't forget that in a very young person who looks like they have emphysema, maybe has some liver involvement or a family history, that it could possibly be an alpha antitrypsin deficiency. So managing COPD, don't forget Prevnar and annual flu vaccine, SABA, add the muscarinic, LABA, max out the inhaled corticosteroids before moving to the oral corticosteroids. So exacerbation in these people, you want to be thinking about if they start to have sputum, give them an antibiotic. All right, great job, guys. Study hard.